All right, so hi, Jackson. Thanks for coming. I've met a lot of you already, but thanks for coming anyway. So obviously, I'm one of the physios that work here, and tonight we'll be going through low back pain, as you know. Talk a little bit about the structure of and the anatomy of the spine to start off with, some of the functions. Then talk a little bit about acute low back pain, then more chronic low back pain, and the kind of cycle that exists with chronic low back pain. A few tips and tricks for what to do when you've got low back pain going on, and then kind of open the floor up to some questions and stuff if you'd like to ask any of those kind of questions. Um, Pretty handy analogy that you can use to think of when you're thinking about your spine is like a chain. So each of our individual vertebrae are like the singular link, and then the singular piece of the chain, and then the links between them are like our facet joints and our intervertebral discs. So I was hoping I could hover the mouse over the top of it, but I can use this one instead. So when we're talking about a facet joint, we're talking about these ones either side. So each individual vertebrae has two facet joints that articulate with the vertebrae above it, and two that articulate with the vertebrae below it. And then you've also got an intervertebral disc that's in between. So they're the links of our chain. Each vertebrae is the piece of our chain. Um, and then, the anatomy of our spine has come together in a way that it's a structure that can both take compressive load and be a centerpiece for the movement of the rest of our body, but then also be rigid, flexible as well at the same time. So like a chain, it can move around, but then also has that. We are lucky enough to have that compressive load, which a chain might not. Like we just said, your spine is the chain that forms the backbone of your body. It's the pillar that supports us from compressive load, and it's the anchor for our muscles and tendons to attach to, so that we can, walk, sit, move around, do all of the things that we like to do. And then the other important role, obviously, for our spine is to protect our spinal cord, so give it that bony casing around the outside, and protect our spinal cord and our neural system, so that we're able to control the muscles that we've got. So without our axial skeleton, which is what we would call our spine, so our head, our spine, and our sacrum, there's nothing for the rest of our the rest of our skeleton to attach to. So that's what we would call our appendicular skeleton. So you've got your axial skeletons, that's the centerpiece, and then your appendicular skeleton, which is your ribs, your arms, your hips, all of the other parts in blue on the picture. And so without the spine being the centerpiece, then the rest of our muscles can't attach for us to move. So it really does become the center of our body for movement and for structure. So when you talk about spine, we always talk about posture. So there's three natural curves in our spine. That is a normal posture that gives you that kind of S shape when you look at it from the side. When you start as a baby, obviously then we've only got one curvature because we're stuck inside a womb in that fetal kind of position. So you've got what we call a kyphosis, which is that C-shaped curve throughout your whole body. Then as you start to develop, you start to develop your other secondary curvatures. First one to develop is your cervical lordosis, and that's at the point where you're laying on your belly and you're starting to be able to control and lift your head, and that starts the development of your lordosis there. And then as you've developed a little bit more to a point where you're standing up, then you start to develop your lumbar lordosis with that compressive load of gravity through standing up. And because of those structural changes, as you're starting to grow and the way that our spine has evolved over time, those curvatures as well as our anatomy really helps to take that compressive load and distribute it more evenly throughout our body. Already talked about those. So obviously then, we're here to talk about our lower back, our lumbar spine, the lowest part of our spine, and so it's the bit that connects our thoracic spine and all of our upper body towards our lower body. So the way that it has developed has to be a little bit larger and more rigid than the rest of our spine because it has to take more compressive load than the rest of it. So we've got larger vertebral bodies, we've got thicker intervertebral discs at our lower part because it has to take the weight and any forces that are coming from our upper body down towards our lower body. So, you know, more of the same kind of here. So your spine is not rigid but flexible. We can move forward, backwards, side to side. We can rotate, and the way that our anatomy has developed, it really allows that. The key point on this slide here is the third one down. So spinal mobility depends on the joints above and below and around it, like your shoulders or your hips, to be able to be mobile too. So from what we've talked about with our anatomy, you know, we have to be able to slide and glide through our facet joints here on one segment to be able to effectively go through our full range of motion at the joints above or below it. And then our spinal mobility directly affects things like our shoulders and our hips. So an example of that is for something like reaching overhead without having adequate extension and rotation through our thoracic spine and the rib attachments to our thoracic spine, then your shoulder blade isn't able to adequately move over the back of your ribs. Sorry, middle bit. Yeah, so cervical spine, thoracic spine, lumbar spine. Yeah, so the top 7 is the cervical, the middle 12 is the thoracic, and then the bottom 5 is the lumbar. Right. So without being able to go backwards through your thoracic spine and then rotate with those rib joints, shoulder blade can't move effectively, and without shoulder blade movement, then as far as you can get up with your shoulders about there. But if you've got all the other movements, then you can go right up. So we do see people with shoulder injuries that come from their thoracic spine, that middle bit, and likewise you see people who have very strong contribution to their low back pain from their thoracic spine. And we'll get to that in a second. So yeah, you know, more numbers there around all of the different parts, the moving pieces, and all of these things need to work harmoniously together for, you know, for everything to be feeling good and moving the way that that we want it to prevent overloading in other areas and changes in mobility. So the big one is here, which is what we were just talking about, what I was about to talk about. So that thoracic curve, you can see through there from being in that long seated kind of posture there, when that person then has been in that posture for a long period of time and goes to stand up, their backs become stiff into that kind of position, and then so to keep their head upright over their feet, the lower back has to curve more, overload some of those structures, and can be one of the contributors to why their back's feeling sore. So I'm going to go back to this one. So this one. So what we're talking about there with the mobility changes effectively is a link in the chain getting stuck. So it doesn't only affect that level and the neural system, the nerves that supply that level that can be causing the pain, but also affects the mobility above and below, and then can compound by having multiple segments creating a pain signal. And yeah, what we were just talking about, how do parts become stuck, and that's from consistent movement through a certain range of motion or lack of use of certain ranges of motion. So if you think about it from when you're a kid, you're able to kind of bend around and do all sorts of different stuff, or like gymnasts and contortionists, they're able to bend and move in lots of different directions because they've consistently used those, whereas this guy isn't consistently using any of his thoracic extension. He's consistently in that position because he's there for work 8 to 10 hours a day, and your body becomes really good at moving through the parts that you use and really, really bad at moving through the parts that you don't use. So it's the old use it or lose it kind of thing there. So mobility work through most of our spine can really help with being able to offload other areas of your spine. Oops. So the question is then, what do you start to do if you're feeling back pain? The rule number 1 there is pay some attention to it and don't ignore it, and put in an action plan to do something about it. So the message there in the second point is quite an important one to understand. So we know that back pain is very common, that nearly everyone experiences it at least one time in their life, if not more. Once you've had it once, you are more likely to have future ones. But somewhere along the line, that message has kind of got misconstrued by society, and we start to think, oh, back pain's normal, I don't really need to do anything about it. That's kind of the complete opposite to what the evidence base is for what we need to be doing when people get low back pain. So research shows that early treatment and prevention can be a good preventative thing for recurrent bouts, as well as decrease the severity of the bout that you've got of back pain, and can be really good at preventing the development of chronic low back pain. And as we all know, if you've had low back pain before, all of the sport and socialising stuff kind of goes out the window when the only thing you can think of is how sore your back is. And then, so the thing there to lead into the next bit is the prevention of the development of chronic low back pain. So we'll talk a little bit about the chronic low back pain cycle now. So that's what this thing is. So hopefully you can all see and read that one. So that's a bit of a graphic that someone's made about, some of the points of your typical chronic low back pain cycle. And this is kind of the point for someone who's had acute bouts of low back pain, but has just palmed it off as normal or thought that it was normal and hasn't done anything about it. And then there's a whole host of things that can lead into each other that make the back pain persistent and also can make the symptoms worse. So kind of make up a bit of a scenario and go through them. So really you could start at any point in this cycle, and then the things can lead into each other. So if we start at like this top kind of corner here, so an example of that, maybe someone's been made redundant at work, or there's not enough going on, or their partner or something like that has injured themselves as well or something, and there's money worries. It can lead to being less active because you're spending all of your time trying to think about work, thinking about money, to kind of care for yourself and your family. Less active leads into loss of fitness and muscle weakness, maybe some joint stiffness because you're not doing as much activity. Then going on from there, if you try to do something now because you've got that little bit of joint stiffness or that fatigue or weakness, you've got things that then start to hurt. You create a no-go list of things in your head because you go, oh no, I can't do that one, that hurts. Sleep problems, tiredness and fatigue kind of come on secondary to a reduction in activity and avoiding things that hurt. And then when you're not sleeping as much because you're back to a bit of pain, then you start getting fearful, you get stressed, anxiety, and you get frustrated because you can trace the things back and go, this all happened because I got laid off from work or whatever. Weight gain and loss then is going to be dependent on the individual, whether they lose weight with stress or whether they gain weight from not doing activity. And then that can really heavily affect your mood, which is proven throughout the evidence that having reduction in mood has a negative effect on pain. And so then the severity of your pain is going to get worse because you've got poor mood, and then that leads back into now you don't have the time or not in a good enough mood to go looking for new work, and the cycle continues. So like that's one kind of example of the roundabout of loads and loads of different examples for how people can get on and off onto that kind of cycle of chronic low back pain. And I'd say it kind of probably looks somewhat familiar, maybe not all of the things, but for each of you guys, for either yourself or for someone that you know, or friend of a friend or something like that. But yeah, the important thing to think of here, especially from what we were talking about earlier, is that once you get onto this cycle, it's not all doom and gloom. You're not going to be on there forever. You can definitely take the exit route through any of these points with some focusing, consistent work from yourself and from a health professional, someone to help you through it. So the main point, the big takeaway one there is take care now. Whether you're in the acute phase of your first episode of low back pain, or you've been riding that emotional and physical roller coaster of chronic low back pain for a while, the takeaway is that no one gets better from doing nothing. So depending on where you are on your cycle, whether you've gone right into that low back pain cycle or you're somewhere earlier on, things like better body posture during certain tasks like at work or at home can be as little as it takes to avoid another episode of acute low back pain that kind of puts you on your bum for a little bit of time. And that's where we come in to help. So then in the situation of someone with low back pain, we become the assessor and the coach for looking for contributing factors that might be starting to cause your back pain or things that can contribute to your low back pain, like thoracic immobility or weakness through your hamstrings or glutes or any number of things there. And so we find out what the factors are and become your coach at addressing each of these contributing factors. And that may include, if there is some of those psychological things on there, referring on to other health professionals. And then, we use a combination of manual work here if you're being in as a patient in here, as well as lifestyle exercise changes to start to put in a plan to address all of your contributing factors. A little aside just from the picture of a little guy lifting the thing there. So everyone has been taught forever, don't lift with your back, lift with your legs. And the reasoning behind that is because, like I was saying before, our spine has developed a really sound anatomy and shape to be able to deal with compressive loads really well. But what we are not so adept with dealing with is what we call a shear load, which is a load that goes downwards and in a diagonal direction. So if you're looking at where the box is compared to his spine, if you draw a line straight down from the box and then a line straight down from his spine, the distance between them is pretty far. And so that creates a line of force through your spine at a diagonal down towards the ground, towards the box. That's a direction that we're anatomically not very adept at. We are good at compression. So the takeaway from that one is, it's, of course, bracing yourself and lifting with a relatively neutral spinal position is going to be great. The more important thing is to have the load as close to your body as you can. So if he brought the box right in between his knees with his knees a little bit wider, whether he squatted down to pick that up or he bent from the hips, because the load is down below his spine, the compressive force is going to be there and the shear force is going to be less. So just anatomically better for picking stuff up when it's close to your body, not good when it's far away. All right, so then, like I was saying, our treatment's focusing on finding the contributing factors and helping manage the cause of it. That could be little things like posture, ergonomical change while you're at work, so a desk setup so that you're not like that guy that was sitting there before, and other things like talking on the phone, watching TV are things that we can assess. And then muscular imbalances, so whether you're stronger on one side than the other for whatever reason, which could create a little rotational moment around one part of your spine that then can overload things down the chain. So just looking at those kind of things. And then, lack of mobility either in other parts of your spine or in the other joints around it can contribute to it as well. So desk computer setup are some of the easy things for you to change that might have an instant change in your low back pain, or might be one of many things that can contribute to it. And then safe lifting, like we were just talking about, keeping things close to your center of gravity, so towards your body when you're picking things up. Little things like that can help reduce your risk of future injury or aggravating the back pain that you've got. And then the other thing that we come into play with help there, so physical therapy for relieving pain and stiffness by using a whole host of different techniques. So the ones that you're most likely to get if you come here are massage, spinal manipulation or mobilization, some superficial heat, but you can do that kind of stuff at home, so we don't use it as often in clinic. Soft tissue mobilization, which is just a slightly different version of massages, and then acupuncture and dry needling, depending on who you see and whether they've done the extra levels of study on top. Less likely to see things like laser or other devices, but they are available. So the major ones are the ones towards the top that you would get if you were coming here. And so a combination of those things to address the symptoms that you've currently got, as well as assessing and seeing what contributing factors you've got and putting a management plan in place. And then also looking at putting in the rehabilitation exercises and the stretches that you might need to help out with any of those contributing factors that we've assessed and found. So here we work under a thing that we call the pain to performance model, which is what this lovely mural on the wall is over here. So that means that the ideology that we try and work under is that people come here in pain. We utilise the assessment and manual skills to reduce the pain, find the contributing factors that we've been talking about, and then the important part of the model for best care for people and the reasoning why it works so well is that the real shift from pain to performance is the bit where we go from continuation of rehabilitation after you're no longer sore and pushing towards leaving through our care in a condition that's better than you were in the first place before you got the original injury. So that's what we try to do, work on the physical contributors and attempt to be going towards leaving in a better condition than you were in the first place. A really good focus throughout that kind of thing from the psychological point of view, from what we were talking about on the cycle before, is having a can-do attitude, which sounds a little bit kind of corny, but having the mentality of I can do this rather than the mentality of I can't do this can be really powerful for someone who's had chronic low back pain. So like an example of that is thinking like if you've gone to the markets on the weekend and then you've got a really sore back the next day, having the attitude of I was able to walk around the markets for 8 hours or 6 hours and carry some pretty heavy bags, and now I've just got a little bit of a niggle in my back, versus the attitude of I used to be able to walk and carry whatever I wanted and now I can't. Just a little shift in mindfulness in those kind of things can actually make a really big difference in the severity of your pain. All right, so yeah, kind of hope I haven't been too scatterbrained and gotten across the point that I've been trying to make, that low back pain has many contributors that can include lifestyle, workplace, activity, and psychological factors, as well as the physical things. And the key to living life without back pain is getting help finding which pieces of the puzzle are contributing for you, because everyone's slightly different, and then putting in the work and putting in the time to address each of these individual things. So some of the daily tips that we talked about, you can start with the day with some gentle movements and mobility work. So that might be as little as when you've woken up in the morning, just rocking your knees from side to side, rocking your hips forwards and backwards before you get up, so that you've got some gentle movements in your lower back and you're feeling a little bit less stiff before you get up and go about the things that you do. Keep the posture in mind when you're in situations like at work or any other situation that's keeping you in a static period for a static position for a long period of time. So even if that's having a little sticky note on the bottom of your computer at work that says move or something like that, some kind of plan in place to not stay in one posture for a long period of time. When lifting things, keep the weight close to your body, and then work on the mindfulness and the psychology associated with it. So celebrate the achievements rather than focus on what you can't do. And then the big one down there, seek help. If you're having an acute episode of back pain, don't ignore it and think that it's normal. So here for the exercise therapy part of things, once you've moved from being like an inpatient coming for hands-on treatment, or if you've just got a niggly back, there's different options that we do here. So Pilates-based clinical exercise programs, which is one that some of you guys have been in some of my classes. So then when you go into the clinical exercise programs, you've had sessions with a physio or an exercise physiologist that has assessed what's going on with you, created a program specifically for what they've deemed is necessary for you. Then you come into a supervised class-based setting with the exercise program that was specifically designed for you. And so that one is most appropriate if you've had like a recent bout of low back pain or have ongoing things like that. The Better Back class is one that I run on Thursday nights at 7 o'clock. And that's more full of people who have had that generic back pain niggle, but not an acute back pain thing, just like that little bit of sore back every now and then, but it's not an acute episode that's put them on their bum for a little while. And that one really works on core strength and control, so that we don't have those sheer kind of forces when we're doing certain things. So working on muscular control around our back to reduce the amount of shear forces on our lower back that could start an episode of acute low back pain. And then working on strength and control of things like our hamstrings and our glutes, which can be really important, especially for people who have to start lifting things up to be able to create tension through those muscles and reduce the amount of load that goes through their lower back. So there's some of the options here. If you're not already doing any of them and they sound like something that might interest you, then you can write next to them Better Back or Pilates for some more information if you'd like. You don't have to. And then so that's just a last little throw out to. So we've got a subscription to a place called CoKinetic, which give us a lot of really handy things like the bedtime stretches, sleep strategies, and little handouts that you can send through to people. So you might have to scroll a little bit if you go looking for them, but so they're on our Facebook page, and both the Loft Pilates Facebook and Instagram, or if there's any of those kind of ones that you're interested in, you can write it again next to your email on the sheet there, and we can send you through ones that might be interested. So whether it's sleeping positions or morning routine, interested in any of those ones, let us know. So questions? Anyone like to ask anything? Yeah. Just dawdling around. Yeah. Okay. I've not heard the term museum back before, but from what you're saying there, it's most of the time in a museum looking at head height or above, from places that I've been to anyway. So that might be slightly backwards lean, a little bit through here, plus a long term of static posture in your lower back, and just that little bit of change from your thoracic spine up above. A little bit of change in your loading might be enough to just aggravate your back a little bit. For things like that, just your little mobility exercises that we're talking about in the morning, those side-to-side kind of things and pelvic rocks, would usually be enough to kind of offset that one. Just get a bit of movement back through those sections of your spine. Yeah.
No bending or something. I mean, you see more gallery, you're going to weigh out.
No. So not while you're going. Yeah.
Not quite as obvious.
Yeah. While you're walking around, if you feel like you're starting to get, you can just do like little weight shifts and stuff like that. Pelvic rocks backwards and forwards, which you're going to work at the same kind of idea as what the things are. If you're going to lay down on your back, might not be as effective, but less stand out that you're trying to do something for your back than laying on the floor. But yeah. Oh yeah, sitting down for a little while for sure. Yeah, But then it's going to be dependent on the case as well. Some people sitting is a much more of an aggravation than standing or long periods of walking around. So if you're one of those people, then sitting might make things worse. It's more because it's like an end range kind of posture. A lot of us sit like that, where you're hanging on the ligament structures rather than sitting in more of a neutral spine. Yeah. Any other things that you want to ask or talk about? Or anything that didn't make sense because I was a bit scatterbrained through parts of that?
I'm sort of interested when you're saying about do nothing.
Yep.
Injury, there's a painful injury.
Okay.
Surely it's not just a good rate, not do anything.
Yeah, so short-term deload, not do nothing. Okay, so the difference there is it's a little bit of a hard one. So the evidence that has every bit of evidence that's ever come out has said that bed rest is not good. You know, bed rest for anything for any sustained period of time is no good. Yes, maybe a short period of 2 to 3 days where you're not doing a whole lot, and then slowly, progressively loading your amount of movement and how much stuff you're picking up and carrying. Yes, but sorry, in my head that's quite different from doing nothing. But I don't know whether I've brought that across properly. So short-term reduction in the amount of activity and load that you're putting through your spine, yes, but then continually not doing anything about it. Yeah, yeah, yeah. The corny physio slogan that's going around is motion is lotion, and you know you can think about any joint you want for that kind of stuff. That one's come out really big with knee osteoarthritis and running. That's been a really big focus in the research recently, and all of that kind of stuff is saying that the long-term belief that running is bad for osteoarthritis for your knee joints, not true. Runners have a much lower incidence of knee osteoarthritis than the general population. Yep. Yeah. Without trying to go too deep into physiology, the principle that you're working under there is called mechanotransduction. Basically, it means that all of the tissues of our body respond to a certain type of load. So muscles is more of a tensile load, whereas bones it's more of a compressive load. And so, you know, running is compressive load after compressive load. And so what that does is stimulate the cells of the bones in that area to start to upregulate growth of more bones in that area. There's always a tipping point where there's too much. So it's like your typical bell curve where you want to get right in the middle. And if you go too much, there's always that overload and there's that inflammatory response and the painful response because you've gone too far. And there's always the bottom end of the bell curve where you've not done enough and then things start to degenerate because there's no stimulus for them to grow. So we try and get in the middle of the bell curve as much as we can, but you know, doing that for every joint and every muscle is quite hard.
Well, it seems you mentioned that we regenerate then.
Yep.
Age.
Yep. Yep.
So that body does deteriorate.
Absolutely. Yes. Disc height is definitely reduced. So there's a lot of physios who've talked about it recently who are probably too far over the other side of the fence. But when you're talking about findings on scans and x-rays and back scans and stuff like that, they're trying to pit for all of the radiologists to put a little disclaimer on there saying this is normal for age-related changes. So yes, there's always going to be some degenerative change on an x-ray, on any kind of scan as you get older. That their point of view is basically saying, you know, degenerative changes on a spinal x-ray is the same as having grey hair. It's something that's going to happen. When you take a scan of, you know, you could take a chunk of the population and scan everyone's backs, and you know, if they're 65 plus, there might be 80% of them will have degenerative change on the scan, and then you quiz them about symptoms, and there might be 20% or less that have current low back pain. So the degenerative change compared to the pain response, there's not much correlation.
We can't do anything to alleviate the degenerative aspect.
No. Well, basically no. The degenerative changes are going to be there as you get older. What you can do is maintain the amount of function that you can use through those structures, so then the painful response doesn't occur. Yeah. So you can have degenerative structures that don't cause you any pain and have really good function, and that's what we're trying to focus with the exercise-based stuff, trying to maximize the amount of function you can get and minimize the contributors to pain responses, and then degeneration just becomes something that's there.
So what are the contributing factors there? So taking, you know, two 65-year-old people who have scans because one of those 65-year-old people might have osteoarthritis in their hips,
Yep.
and the other doesn't.
Yep.
So what's just generally what contributes to one having it and one not having it? Is it genetic as much as
A little bit.
right?
Genetic, lifestyle, a huge amount of pain science stuff is around psychosocial contributors here. So stuff like the stress, anxiety, fear, sleep problems, all of that kind of stuff. Pain science is a really, really big and very complex area. But what they're finding when they're talking physical pain responses, that the psychological and the social effectors on that are as effective, as important, or more important than the physical ones.
So tell us a little bit more.
No. So, no.
That's called delusion.
No, so the shift there though is you go, okay, I know that there's some degenerative changes going on because I am getting older, but I've got the psychological mindset that I can be pain-free through here, and I'm doing what I can to minimize the risk, and I'm doing what I can to manage everything. And then the psychological benefits from doing the physical work can reduce the amount of pain, even though nothing in the joint has changed at all.
There's something I thought of when I saw this first, that there's not really injury there, it's not really age either.
Yeah, I didn't make that one. Take that up with the person. Yeah, no, that is good.
Because there is a place for those things in that cycle.
Absolutely. Yeah, no, I agree. I agree completely with that. That injury is probably the entry point into that for a lot of people, with these other contributing things that happen afterwards.
Shoulder injury, I think the body hasn't recovered from it, even though it was 4 years ago.
Yeah.
It still has pain because of that injury.
Yep.
And surgery required it. Maybe I'm just not doing enough to there. Definitely mind part myself.
Yeah, for sure. Yeah, so definitely, injury, surgery, any of those kind of things can be a way into this chronic cycle, whether it's back pain, whether it's anything. And then so the route that makes sense for me and from the evidence base that we've got for you then to try and break this cycle is to start doing some of those mindfulness things that we spoke about. So reframing the way that you're thinking about the things that you're doing, and then finding the physical contributors that can address that are contributing to it and addressing them. Spending time exercising, doing exercises, increasing the resilience of your shoulder by doing, training all of the functions that your shoulder has to do, and having that mindset of I'm doing everything that I can to make this better can be really, really powerful in reducing the pain response that you get from that area. Yes. Absolutely. Okay. In terms of like supplementation and pharmacological stuff, that's not my area of specialty. But what we do know from a whole host of studies is that when you're in like an osteopenic range for your bone density, so there's started to be some reduction in bone mineral density, but not low enough for it to be true osteoporosis, is that by what we were talking about before, that mechanotransduction, by putting compressive loads through the bone, which is going to be resistance strength-based strength training, so this kind of stuff, lifting weights in the gym, can reverse the effects that are starting to happen. It's very hard to drastically increase your bone mineral density, but it's definitely pretty well written in the literature that you can delay the decline or make it plateau with strength training. That in combination with some calcium supplementation makes sense in my head. I don't know whether there's literature there to say that one's better than the other or together that they're as good.
Quite controversial actually. My question is, No, injections of, well, I don't know, portfolio, that's its name. And it actually encourages bone growth. Yeah, monthly, I guess it's monthly. And then it's calcium. I know I've got, you talked about supplements before. Apparently, I listen a lot to Norman Swan on Radio National, and he is vitamin supplements and all those sort of things. Yeah. But apparently, if you are having these injections, you should be taking vitamin C, calcium, the hospital whilst you're having the polio. My doctor, they're very, she's got to take out yeah, that's right. Because I have had the sort of polio. I've gone from the osteoporotic in 65 to now the osteopenia. Yeah, so, and that's through injections.
Yeah.
But
And
it's very controversial.
and you're loading yourself as well at the same time. So you're doing pharmacological stuff as well as doing, giving the mechanical load at the same time. So doing all the right stuff.
Yeah.
Well done.
And it's also about when you're doing the weight bearing exercises to help you bone density, it's about doing a variety for it. Like I used to say that I walk longer than the day. Said no, because you're doing body weight bearing and walking, if not swimming is going to
Because you're weightless, yeah. You don't have that compressive load through your bone.
Yeah.